So everyone knows Dr. Avgerinos. He's very well known for his work in lytic therapy. He's going to talk to us today about some of the new devices for mechanical thrombectomy. So whenever you're ready, Makis.
I'm very happy to join you now. For me, it's like early afternoon. I'm connecting from Athens, Greece. It's not as sunny as I would like it to be. It's actually snowing outside, but it's only going to be for one day. So we're going to live with it.
You have snow in Greece?
Once a year it does. Well, Peter, I need to thank you. Thank you so much. It's really a privilege and an honor to participate in your grand rounds, particularly connecting from the other side of the Atlantic. I really enjoy it. It's the second time I'm here with you, and I'm going to present a review on percutaneous thrombectomy devices for iliofemoral DVT. These are my disclosures. So the slides are turning, right? Are moving on. So
yeah, we can see them.
Oh, wonderful. So why are we treating DVT? Of course, we are doing it to prevent pulmonary embolism and the associated mortality. We do it to prevent lymph loss, venous gangrene, but it's not that frequent. The main reason we are doing it is to alleviate patients' acute symptoms and to prevent post-thrombotic syndrome. So our target when treating DVT is also the quality of life of our patients, and patients who develop post-thrombotic syndrome don't really have a quality of life. So we know by now that some patients need a lot more than just anticoagulation and compression. And just question yourself, what do you say to a 40-year-old male post-surgery who gets an iliofemoral DVT? What do you say to a 35-year-old female post-gestation when she got an iliofemoral DVT and she has an underlying iliac compression? Or what would you say in a 60-year-old male with a cable DVT associated to an IVC filter? I really don't feel comfortable in 2023 just offering my patients anticoagulation only. And I understand there is a clinical controversy here, but as with all procedures, we just have to use it wisely and not abuse it. And we actually now have good data to back up these interventions, and at least the European guidelines are recommending these procedures in selected patients with iliofemoral DVT. So here is the controversy, and there are definitely some cons and pros. The pros on one side, you can get early symptom resolution, you can decrease post-thrombotic syndrome severity, you may decrease post-thrombotic syndrome rates, and you will improve your patient's quality of life. And there is data for that. But on the other side, there are high associated hospital costs, there are complications, and you may not decrease post-thrombotic syndrome. But isn't it like this in all procedures we're doing in vascular surgery, all throughout surgery? And what if I told you that we now have ways to reduce the hospital costs, reduce the hospital stay, and reduce complications? A few years ago, I wrote this editorial because I believed on the attractiveness of catheter-directed thrombolysis. But if I wrote this editorial again, it would actually be the attractiveness of catheter-directed thrombectomy. And we've seen the landscape is changing. It's changing in myocardial infarction. It's changing in the management of stroke. It's now changing in the management of DVT and pulmonary embolism. We moved from systemic to catheter thrombolytics, and we are now moving to thromboaspiration. All we have to do is choose the ideal candidates and do it right. So here is a decision algorithm we have been using at UPMC, but I also think many other institutions follow this pathway. You need to have an iliofemoral DVT. Femoral popliteal DVTs should be excluded in principle. And ideally, you want to remove the clot up to 14 days. We do have devices. We can selectively choose patients up to 30 days. You're going to assess their symptoms, minimal or no symptoms, threatened limb, or moderate to severe pain and swelling. If they have minimal symptoms, then anticoagulation only is fine. If you have a threatened limb, you know you need to intervene. The difficulty is when you have patients with moderate to severe pain and swelling. Well, for these patients, I choose to wait with them on heparin 24, 48 hours and see how their symptoms are progressing. But it's not enough to keep them on the bed. You need to ask them to walk, move around to see whether they develop like leg pain and swelling. If they're mobile patients with good life expectancy and they still have symptoms 24 to 48 hours later, then this is a good cohort of patients you should target for intervention. Now, what type of intervention? You're going to assess their bleeding risk. We used to say if they're low bleeding risk, you can consider thrombolytics. If they're moderate bleeding risk, you can do pharmacomechanical thrombectomy. If they're high bleeding risk, just use aspiration. But in today's practice, we have multiple devices, and we can consider aspiration thrombectomy for everyone. But let's go back a little bit and see the cons and pros of the different techniques. Every tool has a strength and a weakness. So the thrombolytic techniques are generally smaller and cheaper devices. The lytics can reach in all the remote beds where the clot is. They are vein wall and valve friendly, and we have the majority of evidence. But we need prolonged procedures, prolonged hospital stay. We still have major bleeding events and contraindications. We have relative contraindications. We have major contraindications. And here is the technique where you're going to use a very cheap McNamara catheter or Unifuse catheter, multi-side hole. You're going to introduce it inside the clot and start dripping TPA 1 to 1.5 milligrams per hour. The reperfusion is slow, and sometimes if you only use lytics, you may need up to 3 days to clear the clot. Technically similar is the ECOS catheter. Well, the ECOS catheter will still drip TPA, but you also have the addition of ultrasound. And in vitro studies indicate that ultrasound can clear thrombus by 50%, with a 50% increase compared to a standard dripping catheter. However, that was in vitro, and we now have a randomized trial coming from Switzerland, the Bernutiful trial, where they used the ECOS catheter with and without ultrasound activation, and they didn't actually find any difference in the amount of clot that resolved. Another lytic catheter that we have been seeing around over the past few years is the Avgerinos endovascular catheter. It's like a basket, multiple wires dripping TPA, multiple wires opening channels inside the clot and potentially lysing the clot faster and with a less amount of TPA. On the other side, we have the non-thrombolytic techniques, and these techniques are increasing over the past 5 years. Minimal bleeding risk, no major contraindications. You can get a quick reperfusion, and the hospital stay is much shorter. But the truth is we have limited evidence. These are larger and more expensive devices. You can only get luminal thrombectomy. You cannot get the branches. There's still a risk for venous and a questionable risk for valve injury. And you're going to lose blood because you're not only aspirating clot, you're also aspirating blood. But an indication of where things are going right now is the fact that in the market, there are 32 thrombectomy devices. The Angiojet device still holds. We are most familiar with this. Over the past 10 years, actually, this is a device that was mainly used in the ATTRACT trial. It works in 2 modes. You start with a power pulse delivery of TPA, and then you wait for 30 minutes and activate the thrombectomy part, and it fragments the clot and aspirates it out. Now, they have added this clot hunter device that vibrates the wire to allow circumferential removal of the clot. Now, keep in mind that the Angiojet has a hemolytic effect, and it can cause acute kidney injury up to 1 out of 5 patients, but eventually less than 1% will have a permanent deterioration of the renal function. So patients who have bilateral DVT, patients female gender or single station PNTs had a higher chance for developing acute renal failure in our Pittsburgh cohort. So my suggestion is when you have like a lot of clot and you want to use angiojet, if you have bilateral DVT or iliocaval DVT, you may want to drip for a few hours to reduce the amount of clot before coming back and use the angiojet. So here's a 64-year-old female with left leg pain and numbness. She has a phlegmasia. And I'm accessing here through the popliteal vein. This is where I typically get my access. You can see the clot in the iliac vein. I do angiojet. You can see a good final result. There is a narrowing. This is the area where she got surgery and radiotherapy. Intravascular ultrasound confirms the stenosis. I place a wall stent, 16/90, pre-dilatation, post-dilatation. There is also one more lesion, the common iliac vein. I place an additional stent after some more angiojet thrombectomy, and that's the final result. That's one of the early cases I did like several years back. She also had compartment syndrome, and I had to do fasciotomy. The AngioVac device, well, we're not using it that frequent, but it's a very powerful device for caval clot. It requires extracorporeal circulation. The advantage is that once you go in, you can open the funnel, it's deflated, and you can engage clot inside the vena cava, large amount of clot. Sometimes you need to cut down. We can actually now go in percutaneously. Many times we use the IJ as the access site, and we reinfuse the blood back through the femoral vein. Here's a case with caval clot. Aspirating goes through the filter, and you can take it out. Now, AngioVac came out with the AlphaVac device that there is no extracorporeal circulation needed anymore. It's handheld, and you can remove the clot by actually manually aspirating the way you can see in the. There is actually a hunting mode, aspirating 10 cc's per pool, and when you engage the clot, you can activate the 30 cc aspiration valve. The Penumbra device, we started using it in 2016. That was the Penumbra Cat 8. It worked okay, but it wasn't as big to remove clot from the venous side. Cat 8 actually worked later better in the arterial side. We now have the Cat 12. The Cat 12 has the addition of this lightning device that can differentiate clot from blood. So when it detects blood, it's going to stop aspirating. When it detects thrombus, it's going to initiate aspiration again. So here's a 43-year-old male who had a filter that was never removed. He developed bilateral DVT going all the way up to the filter. And here is my procedure accessing both popliteal veins. You can see the thrombus in the femoral veins, in the iliac veins, and higher up into the vena cava and into the filter. So I place a multi-site hole catheter and drip it for a few hours, and the effect wasn't that great. At this point, I introduced the Cat 12 through a 12 French sheath, going up all the way to the filter, and I initiate the aspiration. And then going down one side and then the other side. You can see now things look a lot better. There is some chronic stuff into the iliac veins. Of course, this needs to be stented. That was the Vichy era. These are now out of the market, but it worked pretty well. I had to continue to go through the IJ and remove some residual clot inside the filter and eventually remove the filter with a good final result. Clot river device, it's getting very popular in the US. Now it's very popular also in Europe. No capital equipment required. You have the clot river sheath and the collection bag. That's practically a basket that you're going to introduce and open it up proximal to the clot. You then pull the basket back and retrieve the clot out of the body. So this is a ruptured aneurysm. Everything went well till he developed swelling and pain 48 hours later. So he has a left iliac DVT. You can see the leg being huge compared to the other. I bring him in the operating room. You can see the femoral vein being open, and you can see clot in the iliac vein and higher up into the vena cava. So here's the clot river sheath. There is a funnel that opens up, and this funnel will engage the clot as it comes out. So I have the collection bag now opened, proximal to the clot, and I'm pulling this collection bag down. Look at the coring element. You can see how the collection bag is coming down. You have to pass it 4 times to engage clot from all sides. And now the collection bag is coming down through the femoral vein. And then further down to get into the sheath. And here's how the clot comes out after multiple passes. And we have a good final result. You can see the clot has completely come out with a good final result throughout. Other devices, and I'm not going to go into detail for this, it's like the Jedi. It was acquired from Abbott. It's the Vedex Medical. It's the Aspirex. It was recently acquired by BD. Quick Clear from Philips, and a lot other devices. We now see them in Europe. You're going to see them in the American market probably a few years later. But to make myself clear, thrombolytic and non-thrombolytic techniques are actually complementary. Lytics will bail out an unsuccessful thrombectomy procedure. Thrombectomy will bail out an unsuccessful thrombolytic procedure. And how do you choose? Well, there are some things you need to take into consideration. How extensive and how old is the clot? Is the IVC involved? Is there an IVC filter in place? For example, if you have an IVC filter, you cannot use the clot river device. If you have an IVC aplasia, you are better with thrombolytics. Can the patient tolerate lytics? How's the renal function? Does the patient have a prior DVT? And what's the available access? Is there a stent in place? If you have a stent in place, you may also be better with thrombolytics. And other things to take into consideration: what's the size of the device? What's the cost of the device? Do I have ICU available to keep my patient if I decide to give lytics? But the most important factor is you being familiar and being comfortable with the device you choose. Now, irrespective of what device you decide to choose, the good outcome is based on following the rules and the principles of a DVT intervention. Target to clear thrombus more than 90% and stent liberally. Typically, these patients need a stent in 70–80% of cases. Pre-dilate, post-dilate, use IVUS to decide the landing zones. If you have to extend below the inguinal ligament, just do it. You need to provide the best possible inflow to retain the patency of the stent. Use IVUS, and we have data now coming from Pittsburgh. IVUS will guarantee a better long-term patency. We compared patients we used IVUS against those we didn't, and it seems there was a significant difference in patency at 2 years for the patients we used IVUS. We now have multiple stents available. They all have significant advantages: predictable deployment, uniform radial force. They are longer. You don't need to overlap as many. And hopefully the patency is going to be better in the long term. But don't get me wrong, these procedures will also fail. They will fail because of poor anatomy. They will fail because of restenosis. They will fail because of anticoagulation. But they will mainly fail because of bad technique. So acute DVT interventions are here to stay, and quality of life matters. Acute DVT intervention has benefits that can be enjoyed when done appropriately. Acute DVT intervention success relies more on following the rules and principles of a deep venous procedure rather than the type of device you use. You need to choose good risk active patients, iliofemoral DVT, 2 to 3 weeks clot, and phlegmasia. So do it right or don't do it at all. And with that, I want to thank you for your attention, and I would be happy to take any questions.
So thank you, Marcus. I mean, since the last time you gave this talk, it seems like they've doubled the number of thrombectomy devices that are now available on the market. So you asked the question during the talk, how do you choose? I mean, when you're working in a hospital, when I was chair, we had to limit the number of devices that we kept on the shelf just because, things expire and they want their money up front. So if you had to pick, you say 2 or 3 devices that you're going to have, which ones would you pick, given the 36 that you just showed us?
Right. So while I was in UPMC, I had the luxury of, we had like a really big volume, and we were enrolling in trials. So we got the opportunity to get familiar with many devices. Now, working in a more constricted environment and not having that big volume that I had at UPMC, I will use a lytic catheter, a simple lytic catheter, if I want to use thrombolytics. And if I'm going to do thrombectomy, I go with clot trigger or the aspirates. But my message should not be that clot trigger or aspirates is better. Any device you use will actually work if you are familiar, if you are comfortable, and if you follow the rules. I don't think there is a single best device.
No, but I think your point is that when you're in a large academic institution where finances isn't an issue, it doesn't matter. I mean, in that situation, when you have too much of a menu, it's hard to get expertise with each individual device. When you're in a more restricted environment, you have to choose. So I hear what your message is. Whichever device you choose, just kind of devote yourself to it and gain expertise with it. And like you said, know the strengths and weaknesses. I think the other take-home message, and this is kind of to build upon some of our previous talks. I mean, last week we talked about the thrombolytic trials. And one of the things that came out of the trials was that they did not liberally stent. If you look at ATTRACT, if you look at CAVENT, and you look at the one from the Netherlands had the worst number of patients who got stented. And I think that's a big point that I don't think is emphasized enough, that if you leave disease behind, these thrombectomy devices where they're going to rethrombose. And the way you prevent that is by opening that channel and increasing flow across the channel. And I think that's something that's really not emphasized enough. But let me ask you one other question. So are these devices also safe to use in the pulmonary circulation, or are some of them contraindicated in the pulmonary?
So the angiojet is not it's not allowed to be used in the pulmonary circulation. It will cause cardiac arrest, asystole. The FDA does not allow it. The clot trigger device, you cannot use it. There's the flow trigger for the pulmonary embolism. CAT12, Penumbra, they're running a trial now. The AlphaVac is also running a trial right now. So they are all right now enrolling. The field of pulmonary embolism is now expanding. The only FDA approved right now is the CAT8 and the flow trigger device for thrombectomy. And the other ones are enrolling. It's a matter of time to have like 2-3 more devices available for PE. And
after you successfully, debulk these patients, what's your post-op anticoagulation protocol? Do you keep them on for life? Do you surveil them? What's your protocol for anticoagulation post-intervention? If I end up with a complex reconstruction, particularly if I end up standing below the inguinal ligament, honestly, I will go anticoagulation lifelong. But if I end up just placing a stent, let's say at the common iliac vein, depending on the type of DVT and the underlying cause of DVT, I can typically stop it at 3 months anticoagulation. Well, or 6 months, or 6 months, depending on the cause of DVT. We'll follow the guidelines. And is it Lovenox, factor 10A inhibitor? What's your choice? Yes, good question. Again, there is no big data, but we typically say 4 to 6 weeks Lovenox, and then you can go like to a DOAC or whatever else is indicated for that patient. All right. Does anybody else have any questions for Marcus? This was a really, I tell you, I appreciate the fact he updated this from last year just because of the number of new devices. This was a really, really good talk. So any questions for Dr. Avgerinos?
I do. This is Zoe, and I apologize. I probably missed this, and you probably already said it, but just I wanted to know the reduction in post-thrombotic syndrome when using lysis?
Well, that's a good question. Let's stay at the trials. There is actually, based on the lytic trials, there is no reduction in the rate of post-thrombotic syndrome, but there is a reduction in the severity of post-thrombotic syndrome. So by offering an intervention, we cannot really promise our patient, based on our background data, that we're going to reduce the rate of post-thrombotic syndrome, but it's not going to be as bad.
Based on
gonna be-
Volta?
Yes,
Okay,
yes.
Yeah, but I think that's an important point that Zoe just said, that because when you look at the Cavan trial, there was a 45 or 50% incidence of post-thrombotic syndrome by Volta. But when you looked at 2 years by SEEP, only one patient had an ulcer. So I think the Volta score, and it's been said many, many times, is overly sensitive. It's the wrong survey instrument, I believe, to use in trying to assess that. So I hear what you're saying based upon the trials and the use of the Volta, that the rate doesn't decrease, but I don't believe that. I think they use the wrong instrument to measure post-thrombotic syndrome. It doesn't correlate with actual clinical symptoms of the patient.
True, true. VCSS, I think actually VCSS showed a significant reduction in PTS.
Yeah, I agree.
thank you.
All right, anyone
No.
else? All right, well, thank you, Marcus. Make it home safely. I know Greeks don't know how to drive in snow, so be careful when you go home.
Enjoy your day. Bye-bye. Thank you again.